Hello, hello, and welcome back to another episode of the 2020 podcast. Welcome to the year 2024. Happy New Year, everybody. I hope everybody's had an amazing holiday season and a great start to their new year. And I wanted to start the new year on the 2020 podcast with a bang. I have one amazing guest, the one and only Dr. Paul Karpecki, the legend of our industry. Thank you so much for being here, Dr. Karpecki. I appreciate you being here.
Thank you, Javier. Happy New Year to you as well. Hope you had a wonderful holiday with your family, your three girls, and I'm honored to get to start a new year. It's such a wonderful time when you start a new year because it's this way to say, hey, let's refocus, let's look at what we can achieve or what we want to accomplish, and it's almost like a new start. So, can't think of a better way to begin it than being on the 2020 podcast. Thank you.
Thank you very much. I appreciate it. I couldn't think of a better way than having yourself on the podcast as well. And I agree. I think we can look at this as kind of a clean slate, make the changes that we want to make and start the year off right on the right foot. I didn't give the little intro I wanted to give here. I'm going to give a really, really small slice of an intro of Dr. Karpecki for those in the industry who may not know him. Dr. Karpecki now lives and practices in Lexington, Kentucky. Oh my gosh, Lexington, Kentucky. However, he is a Canadian at heart, born in Canada in North Bay, Ontario. So we have that Canadian connection, which also makes this more special. He has a residency and fellowship in cornea and runs the largest advanced ocular disease center in the United States, which is, wow, that's incredible. Amongst so many other publications and chairing so many other committees and boards, he has co-chaired the last two TFOS Symposia and will be co-chair again in the next one, which, of course, TFOS being kind of the Bible of dry eye and ocular disease. So that means, of course, Dr. Karpecki is at the top of the pyramid, as we all know. As I said, that's a small slice of your bio, Dr. Karpecki. I'd love to dig in a little bit more into who you are and what you do. How would you introduce yourself? If you're coming across another optometrist who maybe lives under a rock and hasn't heard of you yet?
That's a really good question. I think that's why these podcasts are so great that you do, because you don't ask the typical questions. And I think that's what is refreshing. So if someone came up to me and kind of, I'd really just say I'm a colleague. My goal has always been to strengthen our profession, to advance everyone in optometry in North America. Of course, my heritage is to Canada. That's where I was born. Applied to Waterloo. I almost got into University of Waterloo. I was down to an interview with two people. Well, I actually didn't know it was two. I called because I was in Indiana, and I asked how many people are going to interview for this second opportunity. I guess someone decided to go into another field. They had one spot, and if they're going to tell me like 10, I was going to be like, okay, I'm not going to drive up. But they said, oh, we're only interviewing two. And I thought, well, that's really good odds.
Yeah.
They weren't good enough. Whoever the other person was, they got in. So I ended up being in the States. In a way, it kind of worked out well, because then I still get to kind of, do things like this where I'm still involved in my home country, and also obviously in the US. And so I would just say, I practice, I see over 150 patients a week, very similar to colleagues. I'm still in the clinic primarily, but I've been able to do other things outside of that, like publishing and lecturing. But with, three children at a busy time, they're 10, 12, and 12. It's a big part of who I am. And so that, limits some of the traveling. Fortunately, virtual stuff has helped. And so I just kind of focus on fewer but key meetings. And I think, that's really about it. I really like to think of myself as one of the colleagues was just like you and myself and everybody else. So I'm meeting somebody, I really kind of put it in that perspective. I just happen to be a little more focused on ocular surface disease.
Right. A little bit more focused. That's really interesting. I think UW is probably, I'm sure, have been kicking themselves for the past few decades since you came out of school and started making your mark on the industry. I'm going to ask you the question that I get asked, but I ask, and then I flip, people ask me, Javier, how do you do what you do? Like, you're traveling, you do the podcast, you have practice, you have kids. And my response to them is usually, have you seen what Dr. Karpecki is doing, or others in the industry who are doing like at a whole different level? But I want to ask you that question. How do you manage that, or how over the years have you found a way to balance that? And I know it's not always a perfect balance, but you have your family, and you that's obviously a priority for you. And how do you set those priorities for yourself?
That's a wonderful question, because you're right. You're never going to hit that perfect balance. I always think of the analogy of, because you and I get on planes, even when they have a route, they never follow that exact route. They're
Mm,
usually going up or down depending on turbulence, or adjusting one way, then coming back. And I always feel like that's kind of a little bit of that balance when you're trying to accomplish career and family, knowing that family's your priority, family, faith, that sort of thing.
right.
So I do find I'm constantly navigating. Sometimes I go a little too far this way and I've got to pull it back in. And then, for a while when we had children, I kind of told a lot of meetings, hey, I won't be lecturing for a few years. And they took it literally. Like 6 years later, I got an invitation. So I was kind of too
Mm,
far that way for a while. And,
yeah,
and you just keep balancing it in between. But honestly, the truth to trying to achieve it is, you really do have to have a supportive family, a supportive spouse who, is really dedicated to being a team on this, and
mhm,
making it succeed. And at the same time, you can't abuse that and be always on the road and miss out on life, and then later regret that you had a great career but no real, legacy in terms of your family. And so
right.
it's that balance. And then so on the work side, I've got really an incredible team. They let me see over 50 patients a day because they are
Wow.
so streamlined in what they do. I've had the same team ever since I started this last clinic, which is about a
Really?
decade now.
Wow.
Not lost anyone, fortunately, because there's a lot of turnover within the clinic, but not within my team. And I think that combination of just being surrounded by very impressive people, and a wonderful spouse and family allows you to achieve it, as long as you know your priorities and don't sway too far off the path, to the destination.
That's amazing advice. Such amazing advice, especially coming from somebody who has been doing it for so long and at such a high level. I would, and after I make the comment to the person who's asked me the question, well, after I make the comment about, have you seen what, some of these others are doing? I don't feel like I'm doing nearly as much or as much as I'd like to even be able to do as kind of as goals of us I've set for myself. But the next thing I say, the really the most important thing is having that support at home, just like you said, absolutely vital, because if you're doing something that your spouse and your family are not on board with, it's always going to feel so much harder, and it's not going to feel as genuine and as authentic. um, it's always going to be a lot more work. Whereas if my wife's really on board, she to her credit questions me appropriately, like, okay, what's it going to take, how much time is it going to be away from home, or, what does this mean for the kids and all this kind of thing. And I make sure that helps me keep my priorities in line. But as long as I can answer those questions, then she's right behind me to kind of be like, all right, let's do it. And it gives me so much more energy to do it and do it better.
That's perfect. That's exactly right. That partnership and making those decisions goes really far. It's not unilateral. You're not, just going after what you want to do. You're realizing the big picture. You're partnering with your spouse and the family to say, hey, this is important, but obviously my family's priority. How do we make this all work? And, I love that, because really all the success in the world in a career without success at home is not very successful. You've
Yeah.
really have to be able to say, hey, what are the priorities? What do I want to leave as my legacy long term? And while it is great to serve, the profession and try and elevate it as you do so well, and many of us that kind of focus on that, ultimately the biggest impact we're going to have on life is our children and our family and the legacy that goes through them long term. So keeping that balance, partnering with your spouse, I think they're great insights.
That's wonderful. Wonderful to hear. Let's talk about clinic for a moment. You just mentioned 50 patients a day. I know that not many of us are seeing that many in a day, and the fact that you're, with everything that you're doing, you're still in clinic that 3 days a week to see all those patients. It's really incredible. Can you tell me, what does it look like in clinic for you? How do you manage to see that many patients, and what types of patients are you seeing?
Uh, yeah, it's and so I alternate 2 weeks 1 week, 3 day 2 days 1 week, three the next week. So it's really about two and a half. But you're right, at three, like for example, next week I've got a 3 day week. This week was two. So, but it is over 50, and it's, well, to be fair, it's a little bit of, the way the clinic has evolved over the years. Has gone from being a ocular surface disease center where dry eye patients would come in and would be referred in from ophthalmologists, optometrists, especially my colleagues, rheumatologists, et cetera.
Mm,
But we got really backed up. We got to where my colleagues were calling saying, Paul, I'd love to get a patient into you, but it's 4 months, 4.5 months,
wow.
and they just won't wait that long. So we eliminated direct patients, not fully eliminated them, but they were put to the back. Like they'd have to wait 4 to 6 months. So most would want to see another doctor, a colleague of mine first. And then they would, be referred in. And that allowed us to get to a more reasonable 2 to 3 month time frame now that we're at. So it's 100% referral. The great thing about that, and I even have patients sign a form when they come in saying that I'm not going to be doing anything around spectacles, optical, refraction, dilation. That's got to be, you got to continue to see your primary eye care provider, your optometrist,
Gotcha.
every 6 or 12 months as they direct. And that really helps a lot. And I didn't do that selfishly so I could get 50 patients in. I did that really because I want to respect my colleagues and ensure that they continue to have their patients, and eventually the patients go right back to them and they continue to have their exams. But what ended up happening is that I realized that if you don't have to refract and you don't dilate and you don't do a lot of that pre-testing because it's being done by their optometrist, you can see 50 quite easily because you're just doing a standard, ocular surface examination. I mean, I ask a few questions on a specialized questionnaire I have. I take a look at their eyelids real carefully at the slit lamp. I express the oil glands, put some fluorescein in, and that 1.5 minutes is my entire testing, because the pre-testing with osmolarity and other things is already being done. My hypography is done ahead of time. So I just have to glance at a few things. So it's not that great of a feat if you're doing so little or focusing on such a small area as cornea and ocular surface disease. So it allows it. So it's not a stretch when you don't have to do the big stuff.
Yeah, but that's still, well, I suppose that makes a lot of sense. So a lot of the data gathering, and all of that is eliminated, but there's still a lot of mental processing that needs to happen in that very short period of time. Gathering, you have all that information in front of you, and you have to make these sort of quick and accurate decisions. That already sounds like a lot. And I mean, I wanted to ask you kind of what your process might be there, but that sounds like it would be maybe a bit complex. But if you do have sort of a more straightforward patient in front of you, what would be your approach to treating a dry eye patient? More mild to moderate maybe, or I guess the fact that they've been referred to you, they're not going to be a mild patient, but more run in the mill maybe type of a patient. What type of process do you have when you see the data in front of you?
Yeah, that's really the key. And to be fair, I started my first dedicated dry eye clinic in 26 years ago. Hard to believe. And it wasn't like I knew this would be the future. I'm like, okay, I'm going to go into dry eye because I know one day we're going to have, this be a really important area of practice. It was kind of like I was in Kansas City. I'd finished my fellowship. I was practicing in cornea and refractive, and they're like, hey, we've got this big dry eye population, because we were doing refractive surgery in the clinical trials back then in the mid 90s. And we didn't want to disturb or upset our referral colleagues, optometry colleagues, because at that time in the 1990s, people were actually scared that LASIK was going to take over and we'd have contact lenses. We didn't know. Yeah. So we said to my colleagues, hey, and this I'll tie into your answer in a moment, but we won't take patients from you except for those who are contact lens intolerant, who don't want to be in spectacles, which was enough for us to do research on a few hundred patients. But guess what? Those patients who are contact lens intolerant had dry eye.
Right.
We were doing refractive surgery on almost 100% dry eye patients. And we created this huge dry eye clinic, and nobody wanted it. And it was either this is your role or you don't have a job. And I'm like, I'll take it. At the time, I wasn't ready to go back to Kentucky, which is where I expected I'd be. I did my residency in Kentucky, and things were just doing all kinds of things and busy at that point. So I stayed. And it was frustrating at the beginning, but over 25 years, be 26 now, we're in 2024, so 26 years this year, I've learned that you really have to take the patient and determine the type of dry eye. So a lot of things have evolved over those 25 years, but this is definitely one that has. So if I had a run-of-the-mill patient, let's say the most common, the person who's on a digital device extensively, may have rosacea. They've obviously got an evaporative form of dry eye. So when I express their lower eyelid, and again, it's a 5-second test. You don't need anesthetic. You just need to see what kind of oils come out of the lower central to nasal eyelid. And if it comes out like toothpaste, that's abnormal. And if it comes out, turbid, that's not normal. It should be this thin olive oil consistency. So that's my indicator. So even though I did check for dry eye based on their symptoms, and I took a really good look at their eyelids, had them look down, looking for collarettes and blepharitis, looking for telangiectatic vessels, really focus on that eyelid, because most dry eye, 84%, 86%, according to the LEMP study of all dry eye, involves the meibomian glands. So that does involve a little expression, and it's a simple thing to do: a paddle, your fingers, a Q-tip, but you got to kind of milk that lower eyelid up,
Mm,
see what comes out. I have a lot of residents and colleagues who say, I really would love to do dry eye, but do I have to do the expression? I'm like, well, one, it takes about, 3 to 5 seconds,
yeah.
and you don't need anesthetic. It's really easy to do. And number two, that's like saying, I want to manage macular degeneration, but do I have to look at the macula? That's where 86% of dry eye is. You have no
Yeah.
choice. You got to see what those glands are doing. So let's take the fact that it'll come out paste-like or won't express well. That's going to be to your question, the average moderate patient. They're going to be in evaporative form. So years ago, I would, when I first started, we had nothing but artificial tears. And, and I don't even use artificial tears anymore. I took a term from Doug DeVries where I now call them artificial lubricants, so that
Hmm.
they know they're not really a tear supplement, that we still have to treat the disease, even though
Right.
I still do recommend artificial tears throughout the day or artificial lubricant. So that's all I was doing. And then we started using steroids because that's all we had. We couldn't use them long term, usually prednisolone, stuff like that. And we were getting some success, but not a lot. In fact, I had days where half the patients would come in and say, is there another doctor I could see? I'm like, obviously, I'm not doing great. But that was 20 years ago. We were limited. But I
Yeah.
stuck with it because every now and then you get a few patients. And then over the years, I discovered that if you control the OBIT, the OBIT, the obstructed glands, the blepharitis that's usually present. In fact, Perry did a study, Hank Perry, many years ago, that looked at patients with evaporative dry eye and found that somewhere between 94 and 98% of them had some sort of biofilm, whether it be Demodex or staphylococcal or some bacterial form.
Hmm.
So the B is for blepharitis or biofilm. The I is for inflammation. The T is the tear film. When I started going from just steroids, which is inflammation back then, and tears, which is the tear film, and taking care of the O and the B, we started getting this huge success. And so for
Hmm.
like a milder patient, let me like contact lens intolerant, starting to notice their eyes aren't as comfortable at the end of the day. That would just maybe be for the O, maybe a hydrating compress. That works really well, kind of Bruder or whatever, really those good forms. Number two would be a lid scrub, for the blepharitis. Inflammation might be an omega fatty acid, and tear film might be, lipid tear. It doesn't have to be more complex than that, but you have to cover the OB and the INT. Now, if it is a serious case, you're down to the last 10 glands when you're looking at meibography, you're getting zero expression.
Hmm.
You've got the scalloped eyelid margins. That's also an evaporative form of dry eye because they're likely not getting any expression. Your O might be like an IPL or something that's going to try and get those obstructed glands to where
Right.
they need to be. You definitely have to do a little debridement of the eyelid. You're going to be focusing on things to get the obstruction in control much more aggressively. For blepharitis, you might have to clean up the eyelids. The new, Xdemvy drug that will be coming to Canada, but right now it just got approved in the U.S. For any sort of Demodex would be really handy there.
Hmm.
The eye would probably start with steroids in addition to maybe your omega fatty acids, and the IPL will help that to some extent too.
Hmm.
The low level light therapy works there well. And then for the tear film, I might, be a little more aggressive in the type of tear, maybe HA based tear, your high lows, those sort of things. So you're still treating each level, but you're being much more aggressive because they have so few glands, and you don't want to lose
Right.
more. And I think that's a good way to look at the most common form, because you'll notice I didn't mention plugs unless like 3-6 months later they had a really thin tear meniscus who would come in. But like an aqueous deficient dry eye where the lacrimal glands aren't working, I'm probably going to plug 95% of those patients
Right.
really early on. So you really do have to look at the type of dry eye to then determine what's the most effective method. And there's four types. There's obstructive, I guess, evaporative, which we just covered. There's aqueous deficient, which really you just got to get the tear volume up and get the inflammation controlled. There's mucin deficient. That's where your vitamin A's, your Ocunoxes really help, plus anti-inflammatories. And then there's exposure, which is your inadequate
Hmm.
lid seal cases. And really amongst those four, you've got all your forms of dry eye disease. And unfortunately, there's probably another 15 mimicking diseases from
Right.
EBMD to superior limbic hair to conjunctivitis to eye misalignment that, you know, make it difficult for patients to respond because they don't have dry eye, but it sounds like it. So if you have that, I know it's pretty complex for a simple question. What do you do with the run-of-the-mill patient? But it is really straightforward. It's just identifying what the type of dry eye is, and then it's easy to manage it effectively.
That's a great answer. Thank you. And then, felt bad asking that question because I didn't want to oversimplify such a complex process that you're going through with each person. Of course, you could have 5 run-of-the-mill evaporative dry eye patients, but your treatment might be different for each of them because there's some other small data point that's not the same. And so I apologize for oversimplifying, but thank you for giving that very comprehensive answer, because I'm just thinking about colleagues who might be listening who are into dry eye, but maybe feel like they might be missing a little piece of the puzzle here and there. So I think you may have filled in some of the gaps for some people there. So thank you very much. Wanted to go back to the travel aspect and all of the, you're attending all of these conferences, and I kind of joke with some colleagues that your disclosure slide looks like a page out of a phone book. It's like a million, and it's great, it's amazing, it's incredible. But from all of that, you gain so much insight of what's happening in the industry, and I wonder from that, if you could distill it down to a couple of things that you're excited about that are happening right now, or maybe coming down the pike that you're able to share, that we could be looking forward to, in the industry.
I'd love to, and I'll just one quick comment, because you were very insightful on simplifying. In actuality, I think and it's a great time to talk about that real quickly, and I'll go right into your question, because starting a new year, 2024, I would say one of the things we really have to achieve for this year is to simplify dry eye. We've made it more complex than it needs to be. I love the quote from Mark Twain, who said, if I had more time, I'd have written a shorter letter. When I started working in dry eye, I wrote the long letter. I tested everything. We were doing Schirmer's testing back then, and you name it, to try and figure out what was going on. Today, we've simplified it. And while that sounded fairly complex, really, OBIT is straightforward. You just got to control the obstruction, biofilm, inflammation, tear film. For aqueous deficient, it's tear volume and inflammation. So you get it to where it's so simplified, even though there are multiple options in there. The more you do it, the easier it gets. And I think that's what's going to make it really successful. So I like that. It's funny, because when you first put together like your disclosure side, you almost feel a little, I'm kind of embarrassed. I got so many names up there. People are going to think I'm just looking to work with everybody, but a lot of it's research. And the great thing about research is you get to work with therapeutics and devices prior to approval. And you have a pretty good idea when they come out. You've already, treated 100 patients or 50 patients. And while many trials are masked, you're able to get a good insight that, hey, this thing really works. I had patients coming back saying it's the best their eyes have ever felt. And I got to assume they were on the drug, not the placebo.
Right.
So it's really, I think that helps so much. It's kind of the starting point. It's exciting. You have to have a good team to do it. But I do find it gives me an avenue for these severe patients and just general patients where they've run out of options, where I can say, oh, I've got some research that allow you to do it, or a procedure they can't afford that we could do under research. And so I would say about half of the list is research based. And that's exciting to me, because I could peek into the future of where I think things might go based on what we're studying now, provided they get approval. But, in the last month and a half, we've had 3 drugs, 2 on the market, another one coming, and like 5 approvals. So it does point to where we need to go. The others are, typically companies that are trying to understand the field of dry eye. They'll come in and spend a day, and they'll this is what it's like, and this is what we're looking for. And, I may not be doing research with them, but they've got a drug candidate on the market, or they're trying to figure out how to position things where they're at.
Gotcha.
And then the last might be, really some of these startup companies that I've always had a heart for them of how do they, if they've got a great product, many of them never make it simply because they don't position right, or they don't understand where it might fit in. If you can't find the ideal candidate for a product, you have very little chance of succeeding.
Right.
And if you don't know the patients where this won't work, you're also going to fail, because doctors might try their worst patients, their train wrecks, and because that's what I do, the new drug.
Yeah.
And then they think, oh, this drug really didn't work.
Right.
And they don't utilize it. You've got to identify that ahead of time. So I spent a lot of time trying to do that in terms of its positioning and where it's at. And then some, like Jobson, I'm their chief medical editor. So, that would be disclosure that goes up there. So that's kind of the list as a whole. But yeah, I do find it as really a positive. It's a real good way to help position the profession, to anticipate what's coming down the pike, how to be, legislatively in the right spot for what we're going to see, how to build your practice around what we should anticipate in the next 1 to 3 years. And I see that being the sentinel role for me when I'm working with the companies. But I'm selective too. I only work with companies that have a few key insights. One, the technology has to be something I believe in, I've worked with, I've studied, or I'm using that works. It has to have to be good people that recognize, that you don't want to work in this day and age with people who aren't. And I've worked with good products, but not great people. It doesn't always work.
Mm,
You have to have both. Three, it's got to elevate optometry as well as ophthalmology. It really has to elevate my profession. Four, I got to maintain my credibility. I can't be up there saying this and the exact
yeah,
same thing, somehow.
right.
And then fifth, I want to be able to make a contribution. At this stage, prioritize wise, I'd rather have an impact that helps our profession and the company than just being out there working. So
Yeah.
those are kind of the criteria. And then you end up with kind of a smaller list, even though it is a page from the book, but it has actually come down a little. I've really kind of focused on more startups and trying to get that to the next level. But ultimately, it's to position them and our practices where we should be.
Love that, and I certainly meant it. It was half a joke, but I certainly meant it as a compliment. It's
Oh, I
really
do too.
really impressive, incredible, and
Thank you.
uh, aspirational. I think from the perspective of those of us who are trying to grow within the industry. While I know I'm likely never going to have a phone book page as a disclosure slide, I would be excited to have a few more. Names up on that slide to have known I've been contributing in some way and having some sort of an impact.
That's
Um,
inevitable, and we need that in Canada too. We
yeah,
really do need to have those key people who are making a difference that understand the big picture like you do, because everybody benefits. The profession does, you will, the companies do, and quite frankly, there's probably even greater opportunity sometimes in Canada in the way that the structure is set up,
mhm,
versus vision plans in the U.S. that limit some of my colleagues here.
mhm.
So do continue to do that, and always glad to help myself in any way I can.
Well, I appreciate that. Thank you. That's very kind. And I know, of course, you've already made such a big impact, but the fact that you continue to in these various ways is really great. So, out of all of those, I want to take one thing you said about the kind of startup side of things and come back to that in just a second. Kind of put a pin in that for a moment. But out of all of the stuff that you've kind of been involved in, is there anything that you'd say is like super exciting? Is it the pharmaceutical side? Is it the medical device side? What are you most excited about right now that's happening?
I really am excited about probably three areas that to me seem most intriguing. One is that since we're on the theme of dry eye earlier, and then I'll move off of it a little bit, but is that we're moving away from, not moving away. Every form of dry eye has inflammation. It's inherent. When you lose your homeostasis, the immune system knows how to react. And if you've had it long enough, those T cells become primed. I mean, there's no question dry eye is an immune mediated disease.
Mhm.
Take a person who's been out of contact lenses for a decade with dry eye. You could treat them, get them to a perfect spot, and they put their contact lens back in, and everything comes right back
Yep.
because it's immune mediated. The T cells know how to respond to this, to the effects that have been there in the past. So,
Right.
so inflammation is important, and so is the tear film. But we've never really addressed the causes. We've always gone after the result. That hey, because you've got dry eye, evaporative, aqueous deficient, mucin deficient, exposure, keratitis, or exposure forms, we're going to treat the inflammation that results. But why don't we treat the reason for the inflammation? And now we're finally moving in that direction. Blepharitis is a big cause. We have, Xdemvy approved now in U.S. with plans to get approval in Canada. So
Mhm.
we've, going to have a drug there and here that we're just starting to use. It's only been out about a month, but we're actually 2 months, I guess, it is what we've been using. We've had really good success. I think 2024 will be big for that.
Mm.
At the same time, we've, have, the MIBO drop that came out
Right.
from Bausch & Lomb, which is a very effective drop, lasts like 4 to 6 hours. It addresses the lipid layer. It's kind of a monolayer. It's actually not really intertwining with the lipid layer. It creates its own monolayer that actually prevents evaporation better than healthy human meibum. Very few things are better than our own meibum, and
Mm.
that is addressing the obstruction, the meibomian gland component. And over the next few years, we're going to see a lot more targeted agents like that. That are saying, okay, I'm going to focus on either a specific collagen repair that comes in, or I'm going to focus on IL-17, which is kind of one of the key inflammatory
Mm.
components that are related to dry eye, or the obstruction, the inflammation, the lacrimal gland, to restructure it. And these new drugs that we're looking at are really look like they're doing that. We're
Mm.
getting reversal, and we're getting effects that are much more upstream. It doesn't say we're never going to use anti-inflammatories. You go out and control the inflammation. It's inherent with the disease. But now we're finally saying, okay, how do we target that. And we've been doing the targeting with light treatments and PLs and LLLTs and things for a while. But now we're going to start seeing access to everybody because it could be on the drug side. And then speaking of which, there's much more movement into orals and topicals, including retinal disease.
Yeah.
There's like 7 different companies that are working on an oral anti-VEGF, DR type medications that optometry would be prescribing, so that's going to be a real key. And some of them have moved all the way into topical. And I've always seen, injection being pretty invasive,
Right.
internal, then injection, then orals, and then topicals, and everything's moving in that direction. Now that is more of a 3 to 5 year trend, but it's on track. And there's no way that not one of these 7 or 8 companies isn't going to achieve that, or 3 or 4 that are looking at topical agents. So we're going to see a real movement in there. And then the third area I'm excited about, and maybe I'm more excited about this one because it's moving optometry forward, is the utilization of instrumentation.
Right.
Debriding an eyelid, expressing, averting eyelids, utilizing different minor procedures from clamps and other straightforward things that we need to do to get there. And that whole path of kind of surgical instrumentation, new punctal plugs, new longer duration, those are all in that category of making it easier, utilizing new things in there, and making that work from an optometric standpoint in terms of how we look professional and medical, but we're serving a real need and helping patients in a way that maybe we hadn't done 10 or 15 years ago. That's very straightforward and has a big impact from the instruments we're using, which again is very medical. That doesn't take away from primary eye care. You're still going to want to do both, but now you're fully comprehensive. And that, I think, are the 3 big things I'm most excited. There are other areas I do think we're going to see, if you look at the world of virtual reality, is everywhere. AI is everywhere. We're not going to be immune to that in eye care. In fact, you're seeing virtual reality headsets now for visual fields, for neural lens testing, for dark adaptation, you name it. It's all these VR headsets, and everything's moving in that direction because it works. Some of the newer ones like M&S are showing data that's equivalent to the big stand-on alone, visual field tests. And these are much easier and faster and efficient. Augmented reality virtual is more of what we're doing, but even augmented will come in. And then finally, AI plays a real role. It's going to redefine these algorithms I just described. And even when I've applied a little bit of AI to some of the stuff I thought, I learned that, man, I was wrong on some of the things I've been teaching. So it's going to continue to inform us over. These are longer term trends, but they're pretty exciting.
Yeah, AI is definitely one of those very intriguing, exciting, a little bit scary areas. And hopefully we'll be able to, as a profession, as an industry, get a grasp on it and be able to control it versus the other way around. But time will tell. So going back to one of the things that your third, thing that you were sharing that you're excited about, the equipment and the instrumentation that we have, and then kind of bringing back the other point of like startups. One of the companies I did want to talk about was a small company out of Canada called MyVerter, which is started by Marianne Klassen. That little forceps that make it so easy to single-handedly flip the eyelid. So we've had it just for a month or 2, and we've used it a bunch of times, and I was surprised at how easy it was. But you've of course used it in your practice many, many times. I would love if you could share how it's being utilized and your thoughts on that product.
That's a perfect example. It sounds like minor things with instrumentation because you could do it in other ways and Q-tips and things, but they're much more efficient, much more professional looking, much easier to accomplish what you need to accomplish. And they free up a hand. Sometimes you need 3 hands, like getting mybography on an upper eyelid is a good example where the technician's got to pull in another person to hold the eyelid with the Q-tip so that they can get everything lined up, versus this, you just hold and you can move everything you need to. It holds its position. So that's a perfect example, Javier, of that whole instrumentation side that we underutilize, but I think is becoming a strong trend. So for me, that has been a very valuable tool. And Marianne's a wonderful person. She's obviously been in eye care a long time. Was a optician for when I first met her, and played a key role in that company and the whole dry eye field. So I'm not surprised she would use her innovative skills and come up with something that could help a lot of patients and our practices. And so it's a very straightforward little tool, but it's well designed. It's got, like you said, kind of a forceps design. It has these little grippers that are put on it that you can just use to turn it for one eye. You grab a couple silicone tips. You just place it in them and they come right out with it. And then it's the softer one, has it's like a little flap, allows it to bend over, and you just hold it. So for me, where it's been really helpful is both for staff and for me. And sometimes we're kind of fighting over it. We had to get a second one because the staff, I have them. I started by first only looking at lower eyelids on my biography. And then I realized that, wait a minute, some of these patients have only like 6 or 7 glands.
Mm,
We need to avert the upper eyelid. And we were amazed sometimes how it didn't always correlate. That upper eyelid might have had
right.
many more, but they're very squiggly, or it had the exact same in some cases, or even less. So it became a requirement. And then now it's become a requirement that my staff have gotten so good at it, they can just flip the upper eyelid and both are imaged. Then that way they don't have to have the patient go back for my biography of the upper eyelid. They just know to do them both, and they do
Right.
it in seconds. And so that has really helped streamline it. But then until we got our second one, I was taking it from them and saying, okay, I've got, concretion under the upper eyelid I've got to remove, and
Mm,
I need the instrument to help me see, or a foreign body, or a person just this week who got some dust in the eye, and it had been there for a while. We irrigated and still felt like it was there. And so this really helped to look much more further up to be able to see what was there.
mm,
Again, I didn't quite see anything, but it gave me a chance to irrigate that out real effectively, which I think hopefully it solves it. But wouldn't have been able to do that as well with Q-tips or other avenues that we may have. And so it's not just that it's more efficient, it's better, but it's also more impressive to a patient. That you're utilizing some of these high scale technologies, that instrumentation. They're used to going to other, doctors where instruments are just part of what you do. And we
mm,
use instruments. We have retinoscopes, ophthalmoscopes. It's not a transluminator, it's not a far stretch. It's just these are more the handheld instruments, the debridement, the expression, the upper eyelid, lower eyelid. It also, my verter does lower eyelid aversion. Those sort of tools that I think are valuable. So for us, I had a patient who had like about 30 concretions in the upper eyelid. I'm thinking,
wow.
gosh, I'm going to get rid of all of these. No way could I ever remove them without, having the diverter. But even to remove just one, helps so much to have something that keeps it stable. I don't have to worry about it falling over the eyelid,
Right.
that is, and in place. And then, of course, the big utilization is staff, imaging the upper and lower eyelids.
Yeah, that's huge. I think, of course, in the slit lamp, rather than using a Q-tip and having to flip the eyelid, or some people are really, I can't do the single-handed thing yet. So even as many times as I've flipped eyelids,
Me
I still
too.
use a Q-tip, and so it's like double-handed in there. So now to have the single hand in the slit lamp is amazing, but the staff is where I thought it was going to be the most valuable, right? Because the staff doesn't have the hands-on experience that we have learning how to flip eyelids, and some of these myographers are a little bulky, and to try to get around them is a little tricky and stuff. So I think that's where I was seeing it as being the most valuable.
Yep.
It's really cool to see that you've had experienced that on both sides.
Yeah. Yeah. No, that's a great point. It really is, because you're right. The staff, that frustrates them. They're not going to do well with the Q-tip. They're not going to be able to get that. And that's why I think a lot of times we're not getting that valuable upper eyelid information unless you have an instrument like this. That's really well said.
Yeah, that's great. Well, Dr. Karpecki, there's always two questions I like to ask at the end of each episode. Before we get to that, I'd like to ask, is there any information you'd like to share about yourself, how people could get in touch with you or learn more about you, your dry eye center, anything else you'd like to share?
I think just they could always reach out by email. It's just Karpecki at karpecki.com, Karpecki at Karpecki.com. It's not like Smith. No one was clamoring for a domain name of Karpecki. So it's sitting out there, easy to get, but at least that makes it easy. And you can reach out to me that way. Certainly my clinic's Kentucky Eye Institute in Lexington. They couldn't get a hold of me for some reason, or email was bouncing or something strange. They, could reach out to that clinic. They'll get a hold of me. But no, I'm always honored to receive correspondence, email from colleagues, and especially my Canadian colleagues, since I have a link or a heritage there. But I mean, it's an honor, and any way I can help, I'm always willing to.
Yeah.
So I think that's probably the easiest way. But just encouraging people to move in this direction. It's one of the most rewarding areas ever. Even over the holidays just passed. Um, the number of gifts from patients, and I
Right.
leave that to my staff. That's kind of one of the benefits to them is, hey, you can have anything except the bourbon. I can't keep.
You're in
Get
Kentucky, you
like
got to have the bourbon.
I know, I get like 3 bottles of really, people are just so grateful. and just encourage, so many of my colleagues to, because there's nothing that I do that any one of us couldn't do. It's just I've having to do it for 26 years, you figure out how. But the goal is not for everyone to reinvent the wheel. It's just to say, okay, what works, and how do we take it from here and advance it even further? But that's my only main point. Feel free to reach out to me, but if you want to try and advance that area of your practice, but I would also encourage it, because it's extremely rewarding for patients, for yourself, and ultimately, to make a difference in their lives.
Yeah, that's wonderful. Thank you. And I appreciate that you're so open to communicating and you're pretty quick to respond given how busy you are. So that's great. Thank you.
That's
So the two questions that I like to ask every guest at the end of the episode are, number one, if we could step in a time machine and go back to a point in your life where you were struggling, if you're open to it, you're welcome to share what it was you were struggling with. But most importantly, what advice would you give to young Paul Karpecki at that time?
It's a great question, and there's really no one I think who's achieved anything can say they didn't have a time when they struggled. I think, in fact, that struggle time, that difficult time, helps position you to learn from it. Hopefully, learn from it and advance forward. I bet if you interviewed, and you do this all the time, people, every one of them have a story here. That's why I love that question, because it's so much of life is built on the mistakes, not on, everything's
Mhm.
wow. Whoever you're interviewing, because you're going to interview people who've achieved things, just had this easy road to get there. But no, I can think back to a time when, I'd put in a lot of work, and within about a 6-month time frame, um, most things just crashed. I lost the place I was working at. Way back when, private equity group had come in, not like the ones today, but back then, had purchased the practice and looked at what the other ODs were making and what I was. Didn't realize the history of building this $30 million practice that I was.
Jeez.
Had a lot of time as a single guy for most of my life to be able to dedicate to that. And so, anyways, that they just called and said, "Hey, we're gonna let you go." And I'm like, "Hey, I lost that. Lost a relationship I was in at the time, which wasn't really healthy, anyways. Quite frankly, unfortunately, a house. It was near the financial crisis time when everything had fallen off. In
Wow.
fact, I had a net worth that was negative. This
Wow.
after like 15 years of working.
Oh my
I'm like, I
gosh.
cannot believe this. I mean, everything I could think of, and I lost my dad, who was my best friend,
Wow.
um, in that same year. And so we've all got those, and it just a couple wonderful things. It really brought me to my faith and having to pray and figure this out. It allowed me to realize there were great things that were still there, like my profession, my career, and I had that, and pray that the other stuff would fall into place as it was meant, and really just starting over. I remember talking to Ben Gaddy. He's like, "Man, if I were you, I'd just declare bankruptcy and start all over." I'm like, "I can't do that. It's going to
Yeah.
affect me the rest of my life." And that's partly because the house was underwater that I'd just gotten. And anyway, so it was a tough time. But I think it was the greatest time, because had I not had that, I don't think I'd be on this interview here. I really don't. I think I had a path already in that direction, but it wasn't going to allow me to refocus and to really figure things out and to stop relying specifically just on me, meaning there's bigger things out there.
Right.
There definitely is a path that we're all meant and intended. God may have intended us for us. And sometimes you have to just surrender and figure it out. And that's what I had to do, because everything I thought would work, it didn't work. And it was a time when, I quite frankly thought more stuff I had and bought, like this house and cars, was going to bring happiness. And it sure didn't.
Mm.
So that was my restarting point. And now I look back on it, and it was really the greatest thing. I soon after met my wife, moved back to Kentucky, which where I'd planned to be. Is the only place I kept state licensure, as I knew I was going to end up there. And had 3 children. Soon after that,
Mm.
career took off. Still couldn't find a good job. I had to go to Cincinnati Eye for a while. Had to go to Louisville for a while. I
Really?
was driving to find a job, and then finally things that finally settled in last. But and also in that time, I guess people, most of my friends, their children are in college, they're in careers, they're having weddings, and I've got
Mm.
a 10-year-old and 2 12-year-olds. But it was such a blessing, and it was
Yeah.
the perfect time. And everything happens when it's really meant to. But being single for all that time essentially also helped me to, achieve the career stuff when the time was right. And now I can have a better balance and focus on family while still maintaining elevating the profession of optometry. So yeah, I hit a hard. It was about a 9 to 12 month patch, and
Wow,
all in a row is crazy, but it
that's
was a
incredible.
blessing in hindsight.
Well, thank you for sharing that. I can only imagine how challenging that must have been, and the fact that you, kind of the lesson there was surrendering, coming back to your faith, and then really understanding your path, and then creating what you have now from that. That's really incredible. I don't think well, I certainly didn't know that. I imagine most people listening have not heard that story before. So thank you for sharing that. The last question, given everything that you've accomplished, how much of it would you say is due to luck and how much is due to hard work?
You've heard the adage, the harder I work, the luckier I get. I can't remember who said that quote. They really, they do go together. You've got to put in the effort. But I will tell you, it was Woody Allen said that 90% of success is just showing up.
Hmm,
There's a lot to be said for that. Sometimes people just don't try the stuff that they know they should.
right.
They're like, "Oh, that sounds frightening. I don't think I could speak in front of people. I don't know if I wrote. What if they rejected the paper or the publication?" They just don't show up. They have something that inhibits them from really putting their neck out a little bit to see what could be achieved. And you're not going to have the fullest life unless you do take those chances, those risks. You got to be courageous. You look at anybody who's had a full life, and you'd never see someone who's uncourageous. They're trying things. They're going to go after things. They're going to fail, and they're going to fail forward. And that's the hard work part of it. So you really do have to show up. You really have to put the effort in. But as you do, and especially if you can imagine the vision, like you know where you want to be and you can feel it. You know what I'd like to have in life. And I had to learn this during my hard time, not before. What I thought was the right path failed miserably. The more things I accumulated, the worse I felt because they were all hollow. They weren't anything of substance. And then when I kind of had lost it all, then I started focusing on real important stuff. And when you can visualize it and almost feel like it's there, it's amazing what you can achieve. You still have to do the work, but when you have a direction, somehow your heart and your brain help you get there, and doors open, and things that you
Mm,
can't imagine all of a sudden happen. They're like, that could not have been a coincidence. And the word
right.
coincidence means to coincide. Things are lined up. So it's really a combination of vision, of humility, realizing that sometimes your direction isn't always the one that's going to be most successful. You have to surrender or relinquish and rely on your faith, and then put in the effort, while enjoying the journey. It's not the end point that matters. It's the process on the way, the friends you develop, the relationships, what you learn, how you advance, and that in itself is the successful part, regardless of where you end up.
That's true. That's great. Wonderful answer. Thank you so much, Dr. Karpecki. I appreciate that. Any final words you want to share before we wrap up?
No, just thank you, Javier. Thank you for getting to start the new year with you, and my colleagues in my home country, and getting to be able to share stuff I don't normally share. Just don't get those questions. That's what makes your podcast so special. I'm
Thank you.
used to being on a fair number of these, but they're always just focused on certain areas, disease, career, and there's just so much more. So thank you for more to life, and thank you for the questions, the direction, your insight, and congratulations on such a successful podcast. I could see why it is. I've listened to some of them. I was
Mm,
impressed with them, but you take a different
thank you.
aspect. While you do incorporate the profession, the career, you look at a bigger picture, and that's really refreshing. So I'm honored to be part of it.
Thank you so much. That's very kind of you to say. I appreciate that, and certainly that is the direction I try to take the podcast. So I appreciate that you noticed that as well. So thank you very much, Dr. Karpecki, for taking this much time out of your insanely busy schedule. I really, really appreciate it. And thank you to everybody who's been listening and watching the 2020 podcast, Canada's #1 optometry podcast. I know that this episode had so much insight. I hope you can share it with your friends, whether it's posted on LinkedIn, send a link to your friend via text message, Instagram, whatever it is. Please let everybody know that Dr. Karpecki was here sharing this amazing insight. And I will see you guys in the next episode.